And as you said, no, post lunch, it's always difficult to sort of, keep the audience engaged. But I think it's a very interesting topic, and a lot of changes have happened, especially following the 8A guidelines. So I will try to sort of, cover some of these aspects in this talk on low risk DTCs. So the definition of a low risk DTC itself is in a way controversial. There is no consensus. Prior to the ATA 2025, we all would sort of, define it as either a T1, T2, N0, M0, a tumor that's entirely confined to the thyroid clinical radiologically. Of course, no aggressive histology. And then if it's a follicular, less vascular invasion or no vascular invasion. But after ATA 2025, there has been suggestions that you will have to incorporate molecular characteristics also, apart from the clinical pathological characteristics. Based on all three criteria, you should have a low likelihood of recurrence or mortality, and those is the basis of the classification of a low risk DTC. Of course, the ATA also tells about dynamic risk stratification, molecular profiling, which it suggests can be considered, and AI enhanced imaging of ultrasound that has to be incorporated, which is something that we all possibly may not be doing, at least the majority of us may not be doing in the regular practice. So why do we actually need this definition? I think once we know that one of our patients fall under this category, the larger implication is that the excellent responders by the dynamic risk stratification, they have an excellent prognosis. More than 98% 5-year overall survival, recurrence rates barely less than 10%. But the more larger implication is for the patient. It suggests that the patients can have a conservative treatment, that is hemithyroidectomy or lobectomy, which we keep using interchangeably, the terminology, without regular or routine radioactive iodine ablation. And of course, there is a lot of evolving landscape of active surveillance and ablative procedures in this category. Of course, it's restricted to papillary microcarcinomas, which is less than a centimeter. Also, there are other important considerations. It obviously reduces over-treatment, extent of surgery, radioactive extent of suppression, all those things are decreased. Reduces complications because of some of these treatments. Obviously, because of that, preserves the quality of life, and it is cost-effective also. So there are very, very many other implications of having defined a low-risk thyroid cancers and managing them appropriately based on the guidelines. So there are 4 broad management issues: hemi versus total thyroidectomy, role of prophylactic neck dissection, which Professor Dev is going to talk subsequently, role of radioiodine therapy, and the evolving landscape of non-surgical modalities, which I'll quickly cover. Of course, when we compare 2 surgical modalities, hemithyroidectomy or total thyroidectomy, the first and most important thing is what is the effect on recurrence, and more importantly, what is the effect on survival. And these are landmark trials which most of us have actually grown listening to. The Billimoria's paper, of course, pediatric and poorly differentiated cancers were excluded. There was a high recurrence rate, better overall survival of total thyroidectomy, and this formed the basis for the ATA 2009 guidelines that you should do a total thyroidectomy for all PTCs more than a centimeter. But mind you, this was not adjusted to ETA margins or multifocality, and subsequently Adams' publication in 2014, although the unadjusted cervical overall advantage was higher, no difference between this cohort of 1 to 4 centimeters, and this formed the basis of the ATA 2015 guidelines. But a very recent meta-analysis appeared about 3 weeks prior, and this was in the otolaryngology head and neck. Of course, this was a mixed cohort of patients of low to intermediate risk as well, about 17,000 odd patients. Similar recurrence rates: lobectomy 3%, total thyroidectomy 4%. Disease-specific survival also was not different between the 2 groups. There was an earlier meta-analysis. Of course, the focus was on intermediate risk thyroid cancers, not exactly on the low risk thyroid cancers. Again, this meta-analysis did not show any difference between the overall survival, disease-specific survival, recurrences, or complications. So by and large, the earlier publications, right from Adam to many other studies, although there are some isolated studies that suggest that recurrences may be higher in the hemithyroidectomy group, but by and large, most of the studies, including the most recent meta-analysis published about 3 weeks back, said there is by and large no difference in the. So when you have no differences in the outcomes, of course, you can go for the less conservative option. But what about the effects on the health-related quality of life? Lesser studies are there, and this is one of the largest of the studies in terms of numbers, the Chinese study of more than 1,000 patients, 53% actually underwent lobectomy. So I think majority of the earlier series, you have more than 80% undergoing a total thyroidectomy, whereas in the Chinese study, 53% underwent a hemithyroidectomy or lobectomy. They measured quality of life at 1, 3, 6, and 12 months. At 1 month, it was worse, but again, 6 months and 12 and 1 year, it sort of became bang normal. So again, in terms of quality of life outcomes, also there was no much difference between them. And again, I had reiterated this aspect, lower complication rates in hemithyroidectomy, even when performed by a high volume surgeon. And there are some interesting caveats of this. Sometimes patients are not actually offered the option of lobectomy for some of these patients. And there was a study to suggest that if patients were offered, a lot of patients actually preferred it. So this is something that we as clinicians should keep in mind and have this dialogue with the patients and offer it. And of course, it's a shared decision-making process, which we all have to take. So again, even in low-risk thyroid cancers, there is this subset of patients where we would anyway do a total thyroidectomy, and this is something that we all know: contralateral nodules, family history, presence of a genetic predisposition, exposure to radiation, and sometimes some studies say that presence of Graves or toxic MNG, you would consider a total thyroidectomy. Again, the role of genomic alterations, and this is coming up in a big way. You have these mutations, and BRAF V600E is the most commonly associated with the papillary thyroid cancers. You could have it as a singular mutation or with a co-mutation of TP53 along with TERT or PIK3CA mutations. And again, there was a controversy that if you had this information a priori, whether you're low risk, what would you do for your low risk DTC? Whether you would offer a total thyroidectomy or a lobectomy, and there is still a controversy in this. Of course, in our cohort of patients, when we studied the BRAF V600A mutations, we found that 40% of our PTCs had this mutation. It is a significant predictor of an adverse outcome, and we came up with a risk stratified model of considering age, BRAF V600E, and ETE as a predictive model, and this also has got a huge therapeutic potential. Of course, we are not going to discuss that during this course. Again, the controversy arises, again, the two guidelines. The Korean guidelines that came last year suggested that BRAF V600E mutated PTCs 1 to 2 centimeters was actually downgraded to low risk in the guideline. And they suggested that you could possibly do a hemithyroidectomy in those patients. But in the ATA 2025 guidelines, they actually place it as an intermediate risk, favoring total thyroidectomy in the group. So we don't really know where it stands. Isolated BRAF V600E in a smaller tumor, maybe you can get away with a hemithyroidectomy. But if the tumors are larger than 2 centimeters, both the Korean as well as the ATA guidelines seems to actually favor a total thyroidectomy in this particular cohort of patients. Again, management of prophylactic neck dissection, 2 small randomized controlled trials are there, one by CEPAL and the other by ANN. And both the trials actually showed that in terms of surgical completeness, sorry, I don't know, it's not going, okay, maybe it's going back like this. So in terms of surgical completeness and in terms of response for treatments, banks similar, health-related quality of life also was similar between the two groups. So again, I'm sure Professor Dave will sort of allude to it more. Although the data is limited, the guidelines actually suggest against the use of prophylactic central compartment neck dissections in the low-risk TTCs. The third role is of radioiodine therapy. Again, the guidelines say that you have to have a nuanced approach, no longer routinely recommended, and based on certain observational studies, meta-analysis, and the Istanbul 2 trial. Again, large observational studies of 1,300 odd patients, no difference in recurrence, whether you had surgery alone or whether you added radioactive iodine study. Meta-analysis also did not favor, and as well as the estimates from the Istanbul 2 trial saying that 3-year event-free survival rates was exactly similar in the row, no radioactive iodine group versus the radioactive iodine group. Quality of life also was no similar. So again, in terms of recurrences, in terms of overall survival, in terms of quality of life, and in terms of the need for prophylactic central compartment neck dissection and radioactive iodine therapy, all of it, the evidence suggests that a conservative approach can be good. Again, the things get complicated, especially in the microcarcinomas with the evolving landscape of non-surgical modalities, and I'm sure you have talks on this as well. For active surveillance, and also for ablative therapies. But I really want to bring about a very recent meta-analysis that has come up in the Endocrine Journal in 2024. They actually combine 3 modalities: thyroidectomy, active surveillance, and the ablative therapies. 13 studies predominantly driven from studies from Asia. Of course, they all had a high risk of bias. No difference in the progression-free survival or recurrence or mortalities by either of the treatment approaches. And of course, this is for the papillary microcarcinoma. So in the microcarcinoma group, again, it suggests that you can sort of do one of the 3 approaches. So to conclude, I must say that the treatment or the management options of low-risk DTC continues to evolve. Definitions are continuing to evolve. Our understanding on this treatment, on this disease is continuing to evolve. Definitely, the management has shifted away from total thyroidectomy to hemithyroidectomy, from a routine CCND to no routine CCND, and from routine radioactive iodine to a very nuanced approach of a selective approach. Of course, further ablative therapies and active surveillance is going to complicate this scenario even more, especially in the papillary microcarcinoma landscape. Thank you for the opportunity and happy to take questions.
Thanks, Arvind, for the lucid presentation.
Mike.
My question to you is regarding whether you're using BRAF testing for all more than 2 centimeter differentiated thyroid cancers now.
No, we are not using it, but I guess following the 88-2025 guideline, there seems to be a suggestion.
But in the 88-2025 guidelines, they haven't said that you have to decide your extent of surgery on BRAF testing. That is not there. So that's why I wanted to know whether, because you have given it as a composite, age, size, and BRAF. So I was wondering whether you have started using it in little older patients, more than 2 centimeters. Are you using it for your...
No, this is not for routine. Okay. As a matter of research, we are trying to study it.
Correct.
But I believe that in the future years, I think, again, with your clinical, radiological, and molecular will also play a very, very important role, starting from the diagnostic process. Of course, in prognosis, we know that it plays a very important role, but I believe that following the 88-2025 guidelines, at least majority of the centers around the world are going to adopt it. It is time that some of the high volume centers think about it and try to sort of, have their own data on.
There's only one problem. As you rightly said, 40% will be BRAF positive, and that can go up to around 40 to 60% will be BRAF positive. Right. We'll be doing far more total thyroidectomies because of that. So we have to be a little careful. That was my only, because PTC is going to be BRAF positive in most cases. So we have to be saying how we can add that with, is it just BRAF or you want to add something else with it? And as you have rightly shown, probably age and probably size should be incorporated before going only on BRAF testing.
Yeah, but again, as a possible, if there is a co-mutation, BRAF and P53, BRAF and PIK3CA, these patients will actually go for total thyroidectomy and this will develop. Isolated BRAF V600, I think we still don't know apart without any risk factors as to how to go about, and that's something that is a conundrum that we need to address together.